The highway intervention is grounded in motivational interviewing. The next few slides will review how we use motivational interviewing with advanced care planning. Motivational interviewing is grounded in the trans-theoretical stages of change model. This model is very similar to the client-centered approach of start where the client is. The stages of change model really says that it's inappropriate for us to try to change a behavior when a person isn't ready for it. In the Highway program, what we're really trying to do is help people move forward with any resistance they might have had with regards to advanced care planning and signing advance directives. So with the trans-theoretical stages of change model in mind and that motivational interviewing approach, we know that if I come in and start strongly urging people to sign an advance directive when they are very reluctant to engage in a conversation, it might actually blow up. And so we start where people are, and in those situations, really explore their perspective rather than try to fix or convince. But the stages of change model does suggest that all of us go through a series of steps in the process of change. We don't just wake up tomorrow morning and say, I'm going to do this, but that it is a period of pre-contemplation, contemplation, etc. And sometimes people go backwards, and that's okay, and that's part of that process. Motivational interviewing is also about helping people find their reason and their motivation to change. So, for example, my desire to complete an advance directive might be very tied up in wanting to avoid pain and symptoms if I were really, really seriously ill. Whereas my friend Ruth might really want to have an advance directive because she doesn't want to be a burden to her family. So rather than explicitly ask people what their motivation is, with this approach, we want to just tune in and pay attention to what we're hearing as a person's motivation, and we weave that into our approach. The motivational interviewing approach is also very flexible, which means, again, Ruth and I are in different places, and so whoever's working with us is going to have to start where we are. Understanding too that I might have never heard of an advance directive, and I might need a lot of information about that, whereas Ruth might have signed 5 advance directives already. And so whoever is working with me or with Ruth needs to have a flexible approach based on where we are. Why did we choose motivational interviewing? For starters, one of the things that we've learned is that education alone actually doesn't have a significant impact on changing behavior. And motivational interviewing not only has positive impacts on the people that we serve, motivational interviewing also has positive impacts on the person using it. So people who use a motivational interviewing approach often feel very motivated themselves, and they are less likely to be burned out. Motivational interviewing is also associated with positive feelings about advanced care planning, knowledge, and self-efficacy around advanced care planning. Motivational interviewing has been successful with so many different behaviors. It's been successfully used to help patients adhere to a fluid retention program, treatment adherence, phosphate control, serum albumin levels, diet, smoking, mammogram appointments, gambling, eating disorders, physical activity, and much, much more. For the purpose of this highway project, we are going to focus and hone in on three really important motivational interviewing skills. The first skill is asking open ended questions. So, really trying to focus on making sure that the questions we ask people are broad enough that it gives us lots of information so that we don't have to be drilling people with question, 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 question. Open-ended questions tend to allow the patient to actually have a significant amount of control over what they share, which is important when we are trying to start where the client is. The second skill, and to me, one of the most important skills, is that of listening and empathy. So, one of the things that we know is while often we believe if we ask questions, we get information, but actually listening and providing empathy also provides an opportunity for patients to really feel safe sharing difficult information. And so, when we're talking about something like advanced care planning, which can be challenging, patients tell us over and over again it's really important that they feel understood and they feel safe and feel cared for. And the way that we create that environment is by listening and providing empathy. So we're going to unpack that a bit as well. And then finally, offering information. Obviously, there are going to be times that we need to offer information to patients, but we want to only offer information when we've fully explored and understand the patient's perspective. And that is in part so that we avoid being directive when a patient already knows the solution. And so the premises really is that if we can ask good open-ended questions and we can offer listening and empathy, that often the information we would give someone emerges anyway. Um, However, there are details that we're going to need to be giving about advanced care planning, et cetera. And what we want to make sure we do when we give information is first that we ask permission to give. So we're going to be saying something like, okay, one of the things that I am hearing you say is that it's very important to you to make sure that your family members know that you do not want to be on a ventilator if you're have dementia at some point. And so if the person says yes, that is correct. And then I might say, I'm wondering if it's okay with you if I share with you a little bit of information about how we can establish a plan to make sure that happens. So we're asking permission before we go into giving that information. And we do that so that people feel a sense of control. Likewise, when we give information, if we can give options to someone, that's really important as well because people are more likely to engage in a change behavior when they feel like they have control over that and they own that, which is A, why we don't give information out often, and B, why it's good to give choices because if people feel like they have a choice, then they have ownership in that process as well. I don't think we can overstate how important listening is in a relationship in which we're talking about advanced care planning or really anything difficult at all. I think sometimes we feel like we're, quote, doing nothing when we're just listening and being present. And yet, listening and holding space to hear a person's story is an incredible intervention. So I think we really have to remember how significant it is to be heard. People need to be able to self express and be acknowledged. People need to feel like, in order to share difficult information, that they're understood. And we do that through listening. And silence, if used appropriately, can help a person feel understood without you actually having to say anything. And part of how we do that is setting it up so that people know that we are going to be listening. So sometimes in a new patient encounter, I'll say something like this. You know yourself much better than I do. And the next few minutes, I just want to sit and listen while you help me understand your perspective. There are also a lot of conversation starters that we can use. And I often ask prompts that cue into patients that I've heard stories from other patients. And so I'm preemptively letting them know that their reaction, whatever it may be, is normal. And so you can see in the quote box here, I've said, I've heard that many patients say when they start dialysis, it makes them think about their healthcare in the future. And I'm just wondering what that's like for you. And we do that, and we could begin to have this conversation about future healthcare, which is the roadway to having an advanced care planning conversation. I really like this cartoon because I think it shows what many of us have experienced in a healthcare setting, in which the assessment or the documentation has become the most important part of the provider patient relationship. And when in fact, often what we want is to have our providers turn around and have a conversation with us and to see us and hear us. Um, which again is why I really like this motivational interviewing approach, because it really pushes providers to put their documentation aside, put the computers aside, and have a conversation. For the Highway Project, we really want to conceptualize empathy as our ability to put feelings into words. So, empathy is our ability to demonstrate that we are understanding the emotional experience of another person. And so that means we're using language that includes emotion words, so that in relationship with someone, when we're talking with someone, we're actively thinking about what is that emotional experience this person is going through, and labeling or testing out and trying that emotion on, checking it out with the patient. We also show our empathy through the way we hold our body, right? So that open posture, um, making sure we have good eye contact, that we're not, again, staring at our computer screen or at our form. We know that actually empathy itself can yield a lot of information like a question does, but it has this added benefit of people feeling connected. And when people feel connected to their provider, then it's much easier to have this difficult conversation. When learning about empathy or thinking about empathy, I think sometimes it's helpful to think about what empathy is not. So, empathy is not my opinion. Now, that is not to say that my opinion does not matter, but it's not empathy. So, if I'm like, I think you really should call your daughter, perhaps that's important in the moment, but that's not as effective as an empathetic statement. Praise. Praise is important. Praise is not something that I discourage, but praise is not empathy. Um, because in some way, praise, we could argue, is judgment, right? So it could in fact be, if we overuse praise, we could be leading a client to believe that we're kind of in judgment of them, which means that if they don't do what we're praising them, that we're going to be disappointed. Empathy is also not advice, um, and it's not stating I understand. This is a hard one because I think it's a part of so many of our vocabularies. And so, one of the things I often push folks to do is try to avoid saying, I understand, but instead state what it is that you do understand. So, what I'm understanding is this. Um, so let me see if I've got this straight. You are very concerned that if you get really sick, that you're going to experience a lot of nausea, and you want to make sure that we've got a plan in place so that that doesn't happen. So we're demonstrating we understand. And empathy is not fixing. And most of us go into this profession because we want so badly to help fix someone. And yet, fixing people isn't empowering to people. What is empowering to people is helping them find their own fix, which goes back to this motivational interviewing approach. I really like this levels of empathy that comes from actually a textbook from graduate school. I bet many of you also have from Hepworth, Rooney, and Larson, um, in which it covers the levels of empathy. And so if we can think about kind of a Likert scale, a level one is actually negative empathy. Like we've actually we might actually be creating harm. Um, Whereas a level five empathy is an extremely additive form of empathy. So in a level one empathy, we have very little awareness of the client's feelings, and we might actually do things that block communication. We would have poor nonverbal skills. And we're just very directive. I'd let the hospital decide whether or not you need life support as a level one empathy. Level two empathy is we're sort of beginning to get at the emotional experience, um, but we maybe inappropriately qualify this. And I do see this happen a lot where, especially in role plays where a client will express, so many challenging and difficult things, and the provider will come back and say, it sounds like you're kind of frustrated. Um, and I'll be like, is it really kind of frustrated, or are they really frustrated? Are they really overwhelmed? So just making, a level two is when we haven't quite matched the emotion or the intensity of that emotion. Um, so an example here is you have to be patient. I can see you are upset. Um, a level three empathy is really just basic level empathy. So we are accurately conveying understanding. We're not really adding anything to the context of what we're talking about, but we're also not subtractive. Um, so talking about this makes you sad, and but you also know that it's going to help your family. So we're just accurately conveying what we're picking up on from a client. Level four empathy is an increased level of empathy and additive empathy. So we might, in our response, illuminate something that's unspoken or subtle in our response. So you feel very frustrated with your lack of progress with your health, and you wonder if there's any hope in feeling better. So it's just sort of that extra reach beyond the emotion word. And then finally, a level five empathy is the highest level of empathy. It includes using our voice and intensity and expression, and it connects the client's feelings to previous things that you've learned about the client. So again, we're really using our body and our language to help illustrate this. So an example is, not feeling better has angered and frustrated you very much. I'm sensing that you're unsure of whether the efforts to help will help, and maybe thinking that the healthcare system can't help you at all. So it's putting together other things I've learned about the client in context of what they're sharing in that moment. A guiding principle of motivational interviewing is this idea of resisting the writing reflex. And what this really refers to is how we need to resist the urge to jump in and fix every problem that exists. So, one of the ways that that shows up for many people in healthcare is when a patient or a caregiver is complaining about the care that they receive. Now, please hear me out. That is not to say that we shouldn't address systems that are failing for patients. But first, we need to make sure people feel heard. So if a person is complaining that perhaps their doctor hasn't talked to them about what their health care is going to look like in the future, that instead of immediately being like, okay, so your doctor hasn't talked to you, okay, thanks for letting me know, let me go talk to her and see what's going on. Instead, we would lean into that a little bit. So, reflecting back, so it's feeling really frustrating to you that your doctor hasn't shared more about your prognosis. Client says yes. Well, tell me a little bit more about that. What do you think's going on? What concerns do you have about your diagnosis and prognosis? And so what I'm hearing from you is that you're really interested in having an open dialogue with your physician. What I'm hearing from you is that it's hard to approach this with your physician. So we're really exploring this, and in some ways, though, again, I think from a social work perspective, of course, we want to address systems, but we also want to help empower people to engage in the way that is meaningful for them as well. And that might be having a conversation with whoever we're talking to about how to broach that subject with their physician rather than us dropping it and running off to fix it ourselves. Again, when we do that, when we are doing immediate fixes in complex social interpersonal interactions, we can often cut off the patient or client's ability to do something that's very empowering. And I often think about, like, a really positive feeling I've had in my life is when I'm really proud of myself. And when I'm proud of myself is when I look back and I see the work that I've done, not the work that somebody else did for me. And so how do we help instill that by empowering our patients and clients too? Several years ago, I had the opportunity to interview 33 dialysis patients or patients with kidney disease, their caregivers and providers. And they all lived in rural areas. And I said to them, how do you or would you want a dialysis or nephrologist or palliative care doctor to talk to you about serious illness and palliative care? And overwhelmingly, people told me that in order to have this difficult conversation, they really needed to see that their provider cared. And so I said, well, how does a provider show you that? How do you show someone you care? And they said, they really need to slow down and be present. And interestingly, one provider said to me, or one patient said to me, it doesn't even have to be 5 minutes. It doesn't have to be a long time, but when you're with me, give me your undivided attention. That is what I need. I understand you have other patients to see. I understand that life is busy, but when you're with me, give me that undivided attention. People overwhelmingly talked about how important it was to sit down beside them. They talked a lot about, body language, touching their hand, which of course I know we only want to touch with permission, but the gestures that we use to show people that we care, looking at people in the eye. People even talked about the tone. That one woman in particular said, it doesn't even have to be a sentence. It's not even necessarily the words that come out of your mouth, but the tone in which you share that is so important. Patients talked about how important it is to feel that their provider was interested in them and that it was okay for them to ask questions. A lot of patients said they worried they were stepping on their provider's toes when they asked questions. So, really offering an environment of feedback. And then finally, patients talked a lot about feeling like they were getting run through like cattle. And that's just contrary to slowing down and being present. So we really want to just remember again how important the space that we hold with people is, even if it's for a short period of time, that creates an environment that makes it safe for people to engage in this kind of conversation. Finally, another guiding principle for motivational interviewing is roll with resistance. So here, resistance is not seen as pathological, but really is a normal human response. Uh, and the idea is that oftentimes when presented with new information, if it is coming to us like we are being sold or persuaded, that actually it has the opposite effect, and that is that we say no. And so when we pick up on clients or patients that um, are perhaps, you know, canceling appointments or dodging conversations, um, our response isn't to try to persuade or convince them that advanced care planning is the best thing for them. Rather, we're really going to explore with them uh, what's that about. So, you know, express empathy, acknowledge this might be hard. Having this conversation sometimes brings things up. Again, we kind of go back to looking at the client's or patient's own motivations, and maybe drawing on their skills that they've used in the past to get through other difficult things. And finally, listening out for change talk. So one of the things that we're going to be um, doing is acutely listening for times when patients express they really need to do this. So a patient might say, I'm not ready to fill these forms out or have this conversation. But later on, you hear them say, but I know I'm going to get to a point where I'm really too exhausted to come to dialysis. Right. So when they say that, they're contemplating and thinking about that there's going to be a point in which they might need an alternative care plan. And so we're just paying attention to that and listening for that, and then we sort of elevate that. So in summary, motivational interviewing is a very flexible, person-centered approach that starts where the client is and works with that. It is an approach that's very grounded in listening and empathy and asking open-ended questions. And while we might need to give information out, we do that sparingly and we give options to people and we ask for permission.